continue with the next session, and it's how should I treat my complex case? It's part 2, and it's my pleasure to ask Professor Dimitrov, Dr. Dimitrov, to deliver his presentation.
Здравейте, уважаеми модератори, професор Василев, доктор Стоянов. Много се радвам, че вие сте модератори точно на моята презентация. Уважаеми колеги, необичайно е присъствието на детски инвазивен кардиолог на това събиране. Даже аз самия съм изненадан, но да видим дали имаме основания да сме тук. Това, което искам да ви представя, е един случай, който може да се дефинира като бифуркация, тъй като подхода при лечението на този случай е подобен, тук може би още в заглавието съм допуснал грешка, но това ще кажете в края на презентацията, може би апроча не е same, а е similar, но това ще разберем в края на презентацията. Аз извинявам се, да, разбрах. Презентацията е на английски, за съжаление аз разбрах днеска, че презентациите трябва да се говорим на английски, затова не съм добре подготвен. Моля да ме извините. И така, много от вас знаят, че пътищата на детската инвазивна кардиология и адултната инвазивна кардиология всъщност започват от един общ път. Само че къде е началото на този път е много трудно да се разбере. Тук в това отношение този въпрос прилича малко на общата ни история с Република Северна Македония. Няма да се изказвам политически некоректно, но всички от нас имаме различно становище по това къде започва пътя. За мен е пътя на инвазивната, на интервентната кардиология започва от балона на Бил Рашкин през 1966 година, много преди, и това практически е първата интервенционална процедура в кардиологията. Разбира се, доста по-късно пътищата на инвазивната адултна и детска кардиология всеки поема по своя път. Много често се пресичат, но така или иначе, особено коронарните интервенции върват по своя път. Неочаквано обаче пътищата в началото на 20 век в началото на нашия век отново се пресичат и то при една неочаквана група пациенти. За ГУЧ пациентите, или това са порасналите пациенти с вродени сърдечни малформации, това не е изненада, но пътищата на коронарните интервенции и детската интервенционална кардиология се пресичат неочаквано при вродените сърдечни малформации при новородените деца. Ето моята различна бифуркация. Виждате един съд, който бифуркира на два други съда. Това е ангиографията. На другите две картинки е реконструкцията и скенера. Виждате размера на основния съд е около 3 мм. И бифуркира на два съда, които единия е с размер 3,5 мм, другия 2,5 мм. Сега няма да ви измъчвам и ще ви покажа къде е тази бифуркация. Ето къде е. Всъщност това е бифуркацията на артериалния канал, който се разделя на лява и дясна белодробна артерия. Това е пациент с пулмонална атрезия с междукамерен дефект и дуктозависима белодробна циркулация. Пулмоналната атрезия е ключа, защото тя създава една нова, несъществуваща бифуркация, която трябва да се интервенира. Защо трябва да се интервенира и как се лекуваха тези пациенти доскоро? Метод на първи избор беше хирургията. Тези пациенти получаваха Блейлок-Таусинг шънт или друга анастомозираща операция. От 2010 година или малко по-късно стентирането на артериалния канал доби все по-голяма популярност и то за всеобща изненада флагмани в тази процедура станаха страните, при които достъпа до високо квалифицирана медицинска помощ беше затруднен и продължава да е затруднен. Затова тези страни избраха стентирането на артериалния канал като метод на първи избор. Това се отнася включително и за нашата страна. Другата причина, поради която стентирането на артериалния канал се наложи, е това, че резултатите, даже в световен мащаб, даже в големите центрове в Съединените щати, резултатите от палиативните хирургични шънтове са с доста висока смъртност и голям процент на усложнение. И така, ето е нашата бифуркация. Виждате, при нея има две стенози. Едната стеноза, която съществува при всички такива пациенти. Това е стенозата при вливането на артериалния канал, при бифуркирането на артериалния канал, пулмоналния край към белодробната артерия. Ако имахме само тази стеноза, по вашата класификация бихме я класифицирали като стеноза тип А. Тази стеноза, която ние намерихме при този пациент, е малко по-комплексна и за да е по-труден случай имаме стеноза и на левия клон на белодробната артерия. Формално това е десен клон, но няма да навлизаме в тези подробности, защото от практическа гледна точка е по-лесно нататък да го интерпретираме като лява белодробна артерия. И така, разбира се, тези случаи са най-трудни в тази патология. Ние от 8 години стентираме артериални канали, но случаите, които са комбинирани с стеноза на клона на белодробната артерия, в световен мащаб са най-проблемни и резултатите при тях са най-лоши. Вечерта преди процедурата се консултирах с моя ментор в Малайзия, професор Алуи, който е водещ в тази процедура. Ето какво ни посъветва той, нещо, което вие правите много често. Два водача, единия в левия клон на белодробната артерия, другия в десния, стентиране с стент, който да покрие дълъг стент, който да покрие стенозата на лявата белодробна артерия. Особеното при тези случаи, колеги, е това, че ние сме задължени да стентираме целия артериален канал от аортния до пулмоналния край, защото всеки оставен нестентиран участък води до констрикция и до затваряне в този участък на артериалния канал и компрометира процедурата. Както е казал Джон Ленън, плановете са, живота е това, което се случва докато си правиме планове, как премина процедурата. Така ли трябва да тръгна? Да. Пациента, извинявам се, пропусна го, пациента е на 6 дни и тежи 2 кг към момента на процедурата. 6 days old and 2.0 kilo. Окей. Това е и причината да използваме този достъп, който за вас е малко по-необичаен. Това е хирургичен достъп от лявата каротидна артерия, 4 френча дезиле. Очаквахме водача да попадне, да вървиме по плана и първо да влеземе в десния клон. Очаквахме затруднения при сондирането на стенотичния ляв клон, но това водача попадна там, така че решихме да пренебрегнем доктор Александров. Къде е? Той беше нашия ментор по време на процедурата. Ние работиме всички тези пациенти вече 8 година, заедно с колегите от нашата катетеризационна. Така че тук стъпихме на опита на доктор Александров в бифуркационните стенози и заедно решихме, че да преминем към директно стентиране на стенозата. Това, което виждате, е един балон, който ние използваме за уразмеряване, за да не губиме време да мериме дължината на артериалния канал. без да раздуваме балона, само по маркерите, така определяме дължината на стента. Ето как отворихме стента. Той беше избран добре като дължина. 3,5 мм е ширината на стента, 26 мм дълъг и на следващото впръскване е финалният резултат от процедурата, при който оценихме кръвотока в дясно като добър и затова не продължихме нататък да отваряме през стратовете, но при нас се е случвало и това да се затвори контралатералния клон, което създава допълнителни проблеми и може би следващия път ще послушаме и превентивно ще оставим там водач. Защо тази бифуркация е уникална, колеги? Първо, уникално я прави, разбира се, артериалния канал, защото за разлика от всички други артериални съдове, които познавате, той има доста по-различна структура, което го прави много динамичен. Артериалният канал, знаете, функционално трябва да се затвори на третия ден след раждането, така че той много бързо се контрахира, ако не вземем мерки, а мерките, които може да вземем, са включване на простагландини, които да държат пулмоналния край отворен. Проблема обаче е в това, че пулмонален край над 2,5 мм е много рисков и даже контраиндициран за стентиране, понеже вероятността от миграция на стента се увеличава многократно и опита в тази посока е негативен. Затова баланса между включването на простагландините и тяхното спиране за предизвикване на контракция на пулмоналния край е много деликатен. Ние в много случаи сме изправени пред дилемата да стентираме дуктуси с много по-голям пулмонален край от порядъка на, на 3,5, че даже и 4 мм, увеличавайки по този начин риска от миграция на стента в белодробната артерия. За щастие не сме имали такава миграция до сега. Другото, което е твърде специфично за тази бифуркация, че тази процедура, за разлика от вашите процедури върху бифуркацията, е палиативна. Затова ние винаги, когато стентираме клоновете на белодробната артерия, винаги мислиме за това, че след 6 до 12 месеца на това дете му предстои операция и то точно в тази зона. А отстраняването на стента и щетите, които бихме могли да нанесем върху белодробната артерия, могат да компрометират оперативната интервенция. Диаметъра на стента, за разлика от това, от метода, по който вие избирате диаметъра на стента, при нас се избира съобразно теглото на пациента. Затова ние трябва да нагодиме пулмоналния край на артериалния канал към стента, който съответства на килограмите на детето. И последното, което вече ви казах, ние винаги се опитваме да мислиме в перспектива и за работата, която ще трябва да свърши хирурга. Благодаря ви, колеги, за вниманието.
Благодаря на доцент Димитров за тая презентация. Честно казано, съм, как се казва, speechless. Добре. Коментари, въпроси? Сашо, какъв стент служихте? Оникс, да, защото това ми заприлича, да, ама...
It was 4.0 by, I don't remember the length, Onyx.
Onyx.
Yeah, for a guy that does the both kind of bifurcations, this one is really funny. You don't have any time. It's like acute coronary syndrome. One, you pass the wire and the balloon and the ductus just closes. And we had like 2 cases where we had to put the stent on cardiac
massage
because of the closure of the vessel. It's real fun.
So there are such a type of bifurcations. Vodo?
I have a question. This is a life-saving procedure, if I understand it well. But what is with this kid after a couple of years after growing up?
Just the Professor Dimitrov said that the patient will be operated in 6 months. So this is only
This is
palliative,
procedure.
palliative, just crossing before bridge to operation.
This
Just
is bridge,
to
yes.
leave the patient alive.
This is the bridge to
just to
operation. This
increase the
patient
weight.
have, sorry, Dobry.
Okay, sorry.
This patient have two options. The one option is B ventricle correction, and another option is the one ventricle correction. This is the Glenn and Fontan procedure.
So, thank you. Благодаря ти много. Браво.
So the next presentation is Dr. Nikolaev.
Two bifurcations with two techniques.
Hello to everybody. Thank you for having us. I'm Dr. Nikolaev from Pirogov Hospital. And with my colleague, Dr. Naunov, and our chief of department, Dr. Martinov, wanted to present this interesting case for us with a two bifurcation solved with two different techniques with somewhat interesting coronary anatomy. So that's somewhat the characteristic of the patient. He presents to our ER, a male, 63-year-old. He's a smoker and has a history of a stroke the year before that. After the stroke, the patient had his right internal carotid stented, and from the angio, it was concluded that the patient had a chronically occluded left internal carotid. Patient is a diabetic with somewhat of a lackluster control on his glucose levels. And this presents with angina, unstable angina in the past couple of days. From the lab result, there's nothing really that interesting, except for slightly decreased hemoglobin levels and marginally increased troponin levels. Of course, we did an echo. Echo shows slightly reduced ejection fraction, second-degree mitral regurgitation, and a hypokinesia of the inferior wall of the left ventricle. And naturally, we proceeded to a coronary angiography, which you can see shows a severely diseased left coronary tree. The circumflex is diseased in its distal segment with two osteo-diseased obtuse marginals coming from one osteum. The LAD is also diseased diffusely with nothing that severe, except one chronic occlusion of the D1. And as you can see, the right coronary is also chronically occluded. It's a small RCA, and here you can more clearly see the chronically occluded D1. So, and of course, we administered nitrous without much of an effect on the coronary circulation and the stenosis. As you can see, the patient has generalized atherosclerosis. He has atherosclerosis on his large arteries also. The coronary circulation, in summary, is left-dominated. And there are formed two bifurcation stenosis, one with respect to the circumflex and to the obtuse marginal, and the two obtuse marginals respective to each other. We devised a strategy. Patient is with an elevated syntax score and is viable for CABG. He is a diabetic, insulin dependent, and an informed option was given to the patient. He was really, really reluctant for any kind of surgery. He didn't want any type of kind, and patient was fairly diseased because of his stroke. So, of course, naturally, we proceeded with PCI. And we proceeded to stent the two bifurcations of the left circumflex artery. Distally, the circ was wired, pre-dilated, and after that, of course, stented with a 275 millimeter stent. After that, the two obtuse marginals, prime and second, were sequentially wired and pre-dilated with 2.5 millimeter balloons, up to 14 atmospheres. After with Culotte technique was chosen for this bifurcation, sequentially stenting each of the two, each of the two stents. The struts were opened and a kissing maneuver was performed with two balloons, 2.5 millimeters in size and 12 millimeters by 10 in length. And of course, we did a proximal optimization of the stent. While here you can see that some of the stent was protruding into the circumflex artery. So naturally after that, we rewired to there and pre-dilated the circ, crushing the struts of the stent of the OM. After that, a 3.5 millimeter by 18 stent was implanted, which now is evident with the mini crush technique. And of course, it was rewired. The struts were opened up with another balloon of the obtuse marginal. And the kissing with two NC balloons was done. The one in the circumflex is 3.5 millimeters, and the one in the OM is with a 3 millimeter balloon. And here you can see a final pot of the struts of the circ with a 4 millimeter balloon up to 18 atmospheres. And as a final result, a final spider cranial. So you can see the results from the procedure with a quite nice flow. And the results of the procedure, patient was discharged 3 days later. His therapy was optimized, even though because of the stroke, patient was still on double antiplatelet therapy. He hadn't stopped taking it. His LDL was well within the ranges we wanted, and he was referred for a control angio of the FR and an FR of the LAD. Unfortunately, 1 month later, patient did not present for his procedure, and following that we found this case, we had a scene with another examination. Patient did not have any complaints. His ejection fraction was slightly elevated, not something very impressive, but he did not have any symptoms, and for the moment still refuses sequential PCI, citing that he is feeling well. In the last couple of days, we managed to convince him to have an angio in the next couple of months so we can perform the FR and see the results. Thank you.
Thank you. So, questions, comments? If I see you're impatient.
No, I'm not impatient, but I am. When I see the result is excellent, so no question about that. But there is a lot of metal, and yes, you don't have control, and maybe the patient will be lucky and having no new intervention. But this region, the first marginal, the proximal circumflex, the upper branch of the first marginal, which is the long disease, I would have done something different. I will have stent from proximal circ, entering to the inferior branch of the first marginal, covering that. So we have 3 diameters there. So you choose a diameter for distal, then you do a first pot from the distal to the bifurcation, and a second pot in the proximal circ. After that, you can re-enter. If you want to re-enter towards the distal circ, you can do it. And you can do a kiss. The same for the long side branch. Personally, I would have touched only the proximal part of the vessel, balloon or stenting, but not a long stenting like this. And if you look at the first picture, the first image you showed about the left coronary artery, there is in the first branch of the first marginal, there is some systolic contraction. So maybe it's not, it's something that is a bridge without myocardium outside. So.
Okay.
So I would have tried to have a single stenting plus balloon.
Okay, I am inviting you just next year to try. You have now, as far as I know, you have new CT machine now,
Yeah,
which
we
is
have a new
quite good. And next year, I'm inviting you just to demonstrate what is the follow-up. If the patient still refuses, maybe you can do. They have now very good CT, like ours.
I forgot the point. The most proximal pot you did
Yeah.
was, so there was 2 stents. Huh?
Yes.
So when you are 2 stents, you don't put the distal marker on the carena. Because if you look at the final result, you have pushed a bit the carena towards the side branch.
Yes. So my proposal is just
Just the CT, no angio.
Yes, just CT, no angio, and we will present the results even on our scientific meeting in April. I'm personally curious because it is really interesting case in April. I'm inviting you just to see, to show the follow-up of this case.
Okay.
And of course, the best is angio, but I really, because we are working on this machine and you have it now, just to do CT and we will see how it
Yeah,
behaves.
we've done a couple of CTs on
Yes.
patients,
Yes.
and it's a really
We
good
can,
machine.
we can
Gives
help
a-
you
yeah,
about that.
Yeah,
Okay.
Yeah. Thank you.
Thank you. Thank you so much. Darko Kitanovsky. Darko, So, he is the next speaker. Да не забравя. Обявявам начало на общото събрание, защото нямаме кворум. Виждам, че много хора са дошли, за да си подадат молбите за членство, което много ме радва. И понеже имаме юридически 1 час за изчакване за събиране на кворум, затова обявявам сега началото, което е 11:51, което означава, че в 12:50, грубо казано, тъкмо ще си направим една кафе пауза след кейсовете и след закриването и ще продължим с общото събрание. We have a meeting of General Assembly of our society, so afterwards, just... okay, so Darko.
Hello everyone. It is my great pleasure to be here again, and I want to thank Professor Vasilev and Dr. Stoyanov for the opportunity. I choose this case because I don't really have experience with such a case. Actually, this is my first one case like this, so I hope someone with more experience can give some more suggestions and advices how to treat these patients in the future. So this is an on-call patient, young patient. I was on call. It was 27-year-old male patient with chest pain started 5 to 6 hours before admission. He's smoker and he has positive family history for coronary disease. His ACG is hip with acute T waves, and on echo he has left ventricular dyskinesia. So we proceed with this patient in the cath lab with 6 French radial access. This is the right coronary artery. You can see that there is no disease, but there are collaterals going to the proximal of the LID. This is angio on the left side. We can see a complete occlusion of the proximal LID. And we start with the procedure. So we start with the workhorse wire. Our workhorse wire is BMW, and I cannot enter the true lumen in the LID, so the wire goes anywhere in the diagonal. And I choose to make thromboaspiration, so maybe if we can open something like to see LID where it's going. But we have some TIMI flow in the LID after thromboaspiration. Can you please play the videos here?
Върху екрана да цъкнете да се задвижат картинките. Следващо.
Okay. So this is after the aspiration. There is no flow in LID. So I took a hydrophilic wire, and with a hydrophilic wire I managed to go in the LID. This is in LID. So I make a few thromboaspirations in the LID, and this is the result after thromboaspiration. And I want to, in this situation, I want to see what is happening with this vessel. So I made an OCT. This is the OCT. So we can see in the proximal part there is a lipid plaque and erosion of the plaque, rupture of the plaque, and high thrombotic burden. And I decide in this case to proceed with several attempts of aspiration and give GP2B3A inhibitors bolus. And this is the result after that. This is the OCT after that. So I managed to store timid threefold. There is still a thrombotic material inside the LID, and I choose to stop here with intervention. Patient was symptom-free, and proceed with this treatment. I go with GP2B3A inhibitors IV, heparin, 24 hours, heparin, aspirin, prasugrel, and statin. And after 2 days, again in the cath lab, this is the result. So I made OCT again. We can see that there is no such a high thrombotic burden now inside the vessels, but we can see the ruptured plaque over there, like that. So in this situation, I choose to implant a stent Magmaris. So I proceed with predilatation, 3.5 balloon. This is the result after predilatation. Magmaris, 3.5. Post dilatation with 3.5. And this is final result with the OCT. Good expansion of the stent without malposition, but there is a small thrombotic material protrusion through the stent. And leave patient like this. So this patient is on 2 months now follow-up. He's symptoms free. We plan to make OCT at 6 months and 1 year after this. Thank you very much.
Well, congratulations for this case. I think that that was the right decision. Maybe I personally would be a little bit afraid of living without stent during the initial procedures, and but the winners are not judged.
Yeah, but nowadays it's not recommended to apply this strategy in general in guidelines. It's harmful because of one really big randomized study from Scandinavians. But in selected cases, it's really useful to reduce chance for no refall. And the application of bioresorbable scaffold in such cases is extremely important, and I really congratulate you because I really believe that this is a place of such a technology. And thank you.
It's really challenging case because of the age of the patient. 27 years old patient, just to start to metallize the LAD at 27 years, it's a little bit challenging. So decision to place a bioresorbable scaffold, I think it's good decision. Just I'm not discussing this one. I think that this is one of the possible, at least from the logical point of view. Sorry, yes, Valery?
Because 27 is an unusual age of such a disease. This is a remark that I think is important because very often these patients have thrombophilia, and that should be examined, and if necessary, take long coif therapy. Otherwise, congratulations, this is a great example I would say, for the rebirth of the leaving nothing behind in the coronaries. I mean the bioresorbable technologies. The Vikamenek.
It's a great, first of all, courage to have to leave the patient like this, young patient with acute anterior myocardial infarction, but I don't think that is not better way than this one. Because we always, when you put a stent in a thrombotic plaque, we trap the thrombus.
No, this is no doubt. Just the problem is that there is underlying dissection and the possibility for rethrombosis is still, it's always there, yes. Like Nikki said, it's always there. This is the problem. Because sometimes you need just a mechanical stabilization of the plaque. Itzo?
One single patient. So the common sense works in single patient. So very good decision. The winner takes it all. So
yes.
No comments from the audience.
Thank you very much.
So the next speaker, it's not me, it will be Dr. Maksudov. And finally, Sashko. I don't hear you.
What are your thoughts about DCB in acute settings? Like in this case, he did, maybe he has some challenges, but he has time to do OCT and everything else. What do you think is the place for DCBs in acute settings, especially in young patients?
It's very attractive. It's without any evidence at the moment.
We have a small study with 120 patients for STEMI, DCB, STEMI. And, the results are not so good. The explanation probably that the drug is going into the thrombus and cannot be applied to the vessel wall.
Exactly.
And probably this is...
This case from Dr. Kitanowski is a very good example why DCB will be working are not working well in acute cases, because even with the most proper thrombus aspiration, you saw on the OCT how much remains the thrombus at the end. So you're delivering the drug inside the thrombus, and you don't know, it is very difficult to assess how much drug will be penetrating the wall. In general, yes, maybe, but, and if we look at the results from RICAFI-3, the last study from China, which is the first one which tested the clinical efficacy of DCBs, and DCBs are inferior to stents in large vessels. So in large vessels, in small vessels, they are equal, but in large vessels, at the moment with the current technology, the clinical data, there is only one randomized study for the clinical efficacy of DCB, and it is negative, just to be clear, for large vessels. Oktay?
So, dear colleagues, friends, thank you for the opportunity to present some of our work. As things in life comes in three, good or bad, this is our compilation of 3 cases. You will judge how we managed to resolve them in a good or a bad way. So we named the topic of our presentation is One Hell of a Weekend in Russe. So the compilation of 3 cases in the name of the Father, the Son, and the Holy Spirit. So this is our first case, day 1 Friday. Case about 74-year-old female patient. I want to bold one thing in the history of diseases. That's the prior insult, and the patient was paralyzed in the right with right hemiplegia. She was diabetic. From the non-invasive, only from the ECG, in lateral leads, there was ST depression and negative T waves, nothing specific from the laboratory and from the echo. So we start the procedure doing femoral approach, and in the beginning, we had a problem. There was a dissection, yes, into the femoral common artery. So I want to ask the audience, what would you do? Would you treat the dissection immediately? Would you put a balloon or just a stent and continue the procedure? You will consult the vascular surgeon, or you will just continue with the angio or the PCI, and after that you will decide what to do with the common femoral artery. So what we did, I will go quickly, so I will leave time for discussion in the end. This is the angio of the coronary arteries, nothing specific on the right, non-significant stenosis. On the circ, there is a significant stenosis in the proximal and distal part, and also a significant bifurcation stenosis of the LAD, Medina 011. So this is a clear 2-vessel disease. What would you do? Would you do a CABG, consult a cardiosurgeon? Would you do simultaneously PCI on the LAD and diagonal branch and the circumflex artery, or first LAD diagonal branch and afterwards the circumflex artery? Would you do first the PTA, or you will leave the patient of the optimal medical treatment? Of course, due to the changes in the ECG and LAD involving the diagonal branch, we decided to do the PCI of the bifurcation, predilatation. We put a stent, we did the pot, and the next question is, what about the dissection of the femoral common artery? What about the approach? Would you continue with the right approach? Would you go the contralateral approach, or will you use the brachial approach? And when it's come to the PTA, would you resolve it only with the balloon? Would you put a stent? And what about the cover stent? We have a pleasure to work with such a guru as Professor Vasiliev is, so he did this procedure. This is a contralateral approach. What the intention to do was to go through and through lumen, so left femoral approach. We go with the diagnostic catheter from the right. We externalize the wire. We go to the right. Because the 035 wire didn't want to pass distally, we changed the wire with the 014 wire. And afterwards, we decided to put a Bentley. Why cover stent? Because we wanted to resolve not only the dissection, we wanted to resolve in the hole from the puncture. So the patient, as you remember in the beginning, was with right hemiplegia, so he will not move his legs, and Bentley was the right choice. So this is the final result. The patient is planned for the circumflex artery procedure in 1 month. The second case, in the name of the Son, is the patient that came in Saturday. He had a previous procedure of the circumflex artery. A couple of years ago, he came with the pain in his chest, and from the ECG, Q waves and negative T waves in the inferior leads. The left coronary system was okay, and when we go to the right, this is what happened. Any comments? Exactly. So, this is done with the diagnostic Wright-Judkins. And the main question is how to proceed. Would you do immediately PCI? Would you call the cardiac surgeon if you got one? We got this also a possibility, and it's good to have a friend which is Pope or some kind of priest and start to pray. But we're not so religious. We're confident that we can do everything, and in this kind of situation, what we did, we'd go immediately into PCI. But when we started to give the contrast, the next question is everything well and there's something to worry about? The dissection spread up, also up, involving the right coronary cuspis. And the next questions are what to do. Stop the procedure. To be exactly when, and if we pass with the wires, where should the landing zone for the stent is going to be. Afterwards, to put the stents, and is the surgery an option then? And what about the cover stent as a solution? So we managed to put a wire, and first of all, we put the stent into the ostium, the second stent below the first stent, and the third stent, and after three stents, it looks better, but not quite. We put the fourth stent, and just to be sure, we put a cover stent at the ostium to try to seal the entry of the dissection. We did the flaring, and this is our, just to show there is no angio of the right coronary artery. Right coronary artery is absolutely with T3 flow, but this is the aorta. The flow restored to the right coronary artery, but in this kind of situation, the main question is how to proceed. Is the surgery an option here? The entry point is sealed. We should leave it. I will leave these questions in the end of my presentation. And third, into the Sunday, in the name of the Holy Spirit case. This is a patient, 66-year-old retired patient with familiar coronary anatomy due to a lot of coronary interventions. And he came with the clinic of unstable angina. From the ECG, there is changes into the lateral leads, and due to previous angios done through the right radial approach, we used the ulnar approach. We did it with 5 French. You can appreciate that there is a left dominancy of the coronary artery. There is a small right coronary artery with long significant stenosis into the proximal, involving proximal mid part. The stents into the circ and marginal branch are okay, and there is a bifurcation stenosis of the LAD with the diagonal branch. To be exactly, there is a significant instant rest stenosis of the diagonal branch. So, what to do next? We should leave it as optimal medical treatment. We should do a PCI onto the diagonal branch of the instant rest stenosis, or we should do the RCA, which is not a dominant artery. Of course, we decided to do the diagonal branch, and the question is, we should go with the stent, we should do DCB or cutting balloon. We start first of all with several predilatations. These are the results after the predilatation. We did dratigluten balloon, and this is the result afterwards. The patient complained about the chest pain, and there was a severe ulnar spasm. We could not proceed through the ulnar artery, and the main question is what's next. There's T3 flow. We should leave it like that and do a control angio in a month. or we should change the access point and finish the procedure. We change into the right femoral approach. We go with 2 wires. After predilatations of the LAD, we put a stent. We did POT, rewiring, opening the struts towards diagonal branch, and we did the KISS and repot, and we were planning to finish the procedure, but in that time the patient goes hemodynamically unstable, cardiac arrest occurred, and on the control angio we see this. Thrombus involving, from the left main, involving the ostiums of the LAD and the circ. So, what we should do, as in first case, pray, call Pope, call a friend, or call the cardiosurgeons, or maybe we should do the thromboaspiration, do GP2B3A inhibitors, do the predilatations or direct stents. Of course, we managed to do everything from this. First of all, we did the thromboaspiration, nothing occurred. Then we put a balloon. We managed, and we were lucky to push the thrombus away from the ostium of the left main and from the circ, and the thrombus go to the LAD. So the hemodynamics went a little bit better. Afterwards, we did several dilatations into the LAD, but with not good result. We did the tirofiban and again the dilatations. Of course, this is the result after the dilatations. We go with the stent, we put the stent, and this is the result. So, TIMI3 flow is into the left main towards LAD and to the circ, but the diagonal is lost. So the main thing is what to do about the diagonal. Patient will survive, diagonal is not needed, or we should continue with PCI. We are maximalists, so we go with the diagonal branch. We did the rewiring, a couple of predilatations. This is the result after the predilatation. So, not a good result, so we go with another stent. We did the tap technique over here. After that, the kissing. We did the final post-dilatation, and this was the final result. You can appreciate the good angiographically result with TIMI3 flow into the all coronary arteries into the left. So, what is the outcome of the patient? This is the final result in another projection. You can see that after the procedure, the heart activity and the full volume circulation was restored. There was one episode of paroxysmal lateral fibrillation, which was restored. We managed to restore the sinus rhythm with the infusion of the cordonon, and the patient was discharged 8 days later. So, what are the conclusion from these 3 cases? Is that the complication happens, and we must learn how to detect and treat them, and the experience of the operator is crucial in this situation. So, remain calm and communicate with the team. Thank you very much for your attention.
Yes, Vlado.
Name of this topic is Weekend in Russe. If I could recognize this first case, this is not usual weekend. In same time, this weekend we had ZASINC, our congress in Stara Planina in Serbia. And this first case was a live case.
That was, well, actually the first case was on live.
Yes.
For their congress, and we transmitted to Serbia, and with the puncture of the artery, there was a complication, and we had to manage all this live. And the plan was to examine the coronary circulation, functional assessment, blah, blah, blah. But at the end, we finished with quite an interesting coronary peripheral case, and we had to manage this in 30 minutes just.
Yes.
Yes, that was, yes.
in same day, Professor Dobrin Vasile made this case. Oktay made the peripheral case in our cath lab, and Professor Gelev managed this in our meeting room in some time. Thank you for support and help us.
Thank you, Volo. Okay, so questions, comments? If not, Sashko, you're in good shape already? I'm really glad that our colleagues from Northern Macedonia are here, and from Serbia for supporting us, and I really am grateful personally for your coming and for coming all these years. I hope to increase and to keep our cooperation in the next years. So, Dr. Nikolov.
Hello, everybody. Thanks for the organizers for this perfect meeting again, for inviting us from North Macedonia again to be part of this BBC 2025. Today I will discuss a case similar to the bad weekend, something that actually happened 20 days ago in our cath lab. It's a patient, male, 67 years old, 175 centimeters tall, with an ex-smoker for 30 years, but not smoking for 10 years, with a chronic kidney disease medical treatment only, with diabetic type 2 on insulin, with the previous angio that was done 15 days ago for recommendation for CABG. The patient refuses CABG, and he refers to our hospital with a non-stable angina, and previously he was with a pulmonary edema. So we saw he was stented 8 months ago on the iliac, common iliac artery left side, and after it he was referred for the nephrology for the treatment of the kidney disease. So we appointed this patient for PCI of left main CX and LAD. This was actually the schematic document that we had about the previous angio. So we decided that we will do this stenting with the contrast saver VisiPac contrast. And because there was no pulsation of the radial artery, we decided to start with the distal radial approach. So we do the ultrasound. It was 45 ejection fraction with anterolateral hypokinesia with normal valvular functioning, carotid arteries with some plaques on the left and right carotid artery, and urea and creatinine in some high level that are already known by the patient that we had before. So we start with the distal radial puncturing. The introducer couldn't involve into the artery, so we went with a cannula, we put the wire, we make a predilatation with the 275 semi-compliant balloon, and again the introducer didn't want to go in, so we used the NC 275 non-compliant balloon, and after it the introducer went in, and we put the 7 French slender introducer into the distal radial approach and continued the intervention after maybe 15-20 minutes of predilatation of the radial artery. And we continue with 7 French guiding. We did left side because it was small artery of the right. We go directly to the left side, and you can appreciate stenosis in the circumflex ostium, in the circumflex mid, LAD prox mid, and distal left main that was shown later. So our strategy was 2 wires, one to the circumflex, one to the LAD, make a predilatation of the circumflex, make a predilatation and put a stent, and after it go for LAD, predilatation, stent, put a stent left main LAD, make a kiss, make a pot, and see how it comes, and if it's needed, we will go for the bifurcation stent of the circumflex. So we continue briefly and really fast. We put the wire into the circumflex, make the predilatation with the 2.5 by 20 balloon, and we already was choosing the length of the stent, and when we do the shot, there is a perforation. I immediately inflate the balloon, and what happened? I was with 2.5 semi-compliant balloon, 16 atmosphere, not that forcing the balloon, and I was stopped and I was watching what did I do wrong. So I let the previous picture again to see it again, and this is our first mistake. When you're rushing to finish the procedure and you're too confident that you're in the right place, you will see that actually from the proximal part of the circumflex there is a side branch, and when the caudal view they are overlapping with the circumflex. And actually I was into the side branch of the circumflex thinking that I am into the right circumflex artery. So after this mistake, we inflate the balloons, we gave vitamin K to provoke the coagulation cascade, and wait for 10 minutes. And because we were with the 7 French guiding catheter, we decided to continue freshly to the stenting LAD. So we make a new strategy. While inflation of the balloon in the circumflex, we will prepare the lesion of the LAD, put stent in LAD, mid-distal, mid-portion, proximal portion, check the perforation. If the perforation is okay, exchange wire to the circumflex artery, stent the circumflex artery. If it's not perforation occluded, we will put a graft stent and continue to the left main LAD. So that's what we do. We make a predilatation with a semi-compliant 2.5, and after it with the non-compliant 275 by 20 for several times on LAD. And this was the result after the predilatation. We put a stent to the LAD mid portion. It was 275 by 48 on 16 atmosphere, and continuously back to the proximal mid portion with the direct-eluted stent 30 by 28 on 16 atmosphere. In the meantime, we decided to check how is the perforation doing, and she's still here. So, because now we are, again, as I said, with the 7 French, we are common to work with 2 balloons, 2 wires, 3 wires, 4 wires. I took another wire, I put it with an inflated balloon to the circumflex of the proximal part. On the other wire, I already put the second balloon, deflate the balloon, and the wire smoothly went directly to the where it's supposed to go, to the circumflex distal part. Inflate the balloon and continue with the LAD stenting of the LAD proximal part. So we put the stent 3.5 drug-eluted stent by 23 in LAD prox, and after it we continue with the, I think I didn't let the predilatation. We made a predilatation with 275 by 25 of circumflex medial part, where you can appreciate that there is no perforation into the side branch that was before. We put the 30 by 38 on 14 atmosphere, and this was the result after the stenting. So we continue with intervention, stenting left main towards LAD. So we finish the procedure to come to the end. We place the stent ostial left main to LAD. It was 40 by 28, I think it was. So we make a pot after the stenting. After the pot, we make the rewiring to the distal strata, I hope, of the left main stent, make the keys, make the pot, make an optimization of the ostial part of the stent of the left main, and this was the final result. There is a optimal flow of the circumflex. There is no need, no dissection. TIMI-3 of LAD, TIMI-3 of circumflex, no perforation. The patient was stable, and we decided not to make more damage to the patient, to stop the procedure here. So we made immediately ultrasound. There was some pericardial effusion behind the left ventricle around 4 millimeters, and sorry for my voice, in front of the right ventricle around 5 millimeters. We were following this patient for 3 days, and we discharged the patient after 2 days because there was no evolution of the effusion. Stable patient, and actually he's now perfectly fine. Even the grades of the creatinine and urea with the Visipac didn't raise up at all. So take-home message: always make a strategy and follow the basic rules of interventional cardiology as simple as possible. never speeding in cath lab because you will always make a mistake that will harm somebody's life. And confidence is something that we must leave it in front of our cath lab. No matter how many years of experience or cases we have it, the confidence must stay in front of the cath lab, because otherwise we will be too confident to do something that is not probably right, as it was this case. So as Confucius says, if you make a mistake and you don't fix it, then it's called a mistake. Thanks for your attention. And I just want to say this is a very, very, very important meeting for me and for my team from North Macedonia, because I remember 2015 was the first time when we came. I think it was in some other room, there was the projection, the presentations, and I was presenting my first culotte. I was happy that I did it with the two bare metal stents on circumflex and obtusa. And I remember that I was having a problem with the wire because it was going through between the intima and struts, and I didn't know about the pot. And I knew the pot, I learned the culotte, I learned the decay crash, I learned the final pot. Now we are learning the POCI. So Štip, cardiology in Štip is developing regarding to Professor Dobrin Vasilev, Professor Gelev, of course our teacher, let's say, Professor Ivo Luvart, who are actually our idols where we want to come with our career. Thank you guys for having us here.
Well, thank you, Sashko, for your kind words. And so, some questions, comments? It was really good that you can escape placing a covered stair. Just sometimes it happens that we have to close such type of perforations at the place of bifurcation, sacrificing one of the branches, just stenting with the graft stent across the bifurcation. But fortunately here, everything finished in a good way. So congratulations.
We usually give vitamin K.
Yes, but vitamin K starts working because it works through the hepatic metabolism. At the beginning of the action of the vitamin K is between 4 and 5 hours. So the protamine is the standard treatment, if just to neutralize the heparin. And because with as I said, the vitamin K starts working quite a little bit later. This involves the metabolism of the factors of the blood clotting. So, thank you. And Valery? Please take a microphone because I'm not hearing you.
Congratulations, it's a great case, but some caution in this case is because it's a great delicate balance between protamine and putting new stents in the radiant left main. Because this could go in an unpredictable direction. And what I think is, for example, a question, if this perforation starts bleeding again after you have put a stent into the left main, it was going to be extremely difficult to go with a stent and with a cover stent and to sew it. So all these things should be evaluated, and what I was going to do is just seal the perforation, see that everything is clear on the next day, and you can go and continue the procedure. Probably that's because of the bad experience that we have that is going to do. It is the same, and sometimes you know that, for example, distal perforation from the wire, they seems very not troubling, but after some hours they are coming up, and that's a problem.
Okay, so thank you for your comment, and I'm closing this session. It was almost like last year's session, Nightmares in the Cat Lab. And just would like to invite Yves and Valerie just to close the course and to say some closing remarks.
If we're at the end of this event, please.
So, the oldest, the first. I'm coming to this meeting since the very beginning, probably. But with time, I want to thank you for the invitation because you are taking a lot of care of my brain function. So if I don't have this this kind of meeting, if I'm not back to the excitation that we had doing the 40 years of work, I will probably do only gardening, and it will be probably. My brain will be probably not as good as it is today if it's really good. So thank you very much for the invitation. I like this kind of meeting. I think mixing science and tips and tricks and experience and description of technique, improvement of techniques. I think this is a way to progress. In our group, we are progressing, discussing all the cases together. We are progressing. You can also progress with Proctor in the Cat Lab, but this kind of meeting with people close to each other, you can progress in your daily practice. So I think for your country as for others is very important, and for yours. This is a unique one. Unique meeting on this topic. In France, we had much more, but sometimes if you do several meetings, all people are not saying the same thing. So I think, okay, this is very important for the development of the technique here and elsewhere. Thank you.
I'm really happy to see a lot of people at the end of the program. This Congress, in my mind, is really successful. This year we have a lot of people in the audience compared to the other years, and as we spoke with Professor Vassilev yesterday, we will keep our consistency to perform such I really believe, high-level meetings. And in the last 3 days, we saw that really high-level science can be really connected to everyday practice, as Professor De Bruijn showed us and their team. And I really believe that this meeting is really valuable for Bulgaria and near countries as Macedonia and Serbia. Thank you.
So, finally we are at the end. It was quite a tough task to keep pace all these 3 days. But first of all, I would like to thank you, all of you, staying till the end. I would like to thank to our faculty. Some of them are already in planes, but they supported us, and I'm really grateful for their support. I would like to thank also to Denica and her team, and the guys from Congress Technique who are supporting us all these years for the transmission and for doing the course better and better. And I hope that next year you will be again here. We have next year will be 15 anniversary of our BBC course. So if I really strongly rely on your presence next year, just right now I'm still inviting you, and for sure for 15th anniversary, I hope.
I will do my best, if my garden is okay. So.
Yes. So, Valery, just a few words.
So, we should close it. Thanks to all. Just to include the staff and the team from the cardiology clinic here, because they did a lot for wife cases and whatever it was necessary. And see you tomorrow, no, but next year. Thank you.